This is the introductory lecture for the teaching modules of the One Health Regional Network, or HORN, project. This lecture is the first in the Tier 1 One Health curriculum. My name's Rod Chrisley and I work at the University of Liverpool in the UK. My research interests focus on the intersection between human and animal health, and I use a range of tools from epidemiology and sociology for this. This lecture will provide a very short overview of One Health as a way of introducing subsequent lectures. So when thinking about One Health, it's useful to think about the history that has led us to our current concept of One Health. And I want to address this very briefly, just in two ways. First of all, I want to talk about the rise of what might be considered disciplinary science, or the modern scientific disciplines. The concept of having distinct scientific disciplines, it really is not that old. It became particularly prominent in the 19th century. And this sort of disciplinization, if you like, of science led to the rise of specialization amongst scientists. So scientists would develop within different roles, and it led to the creation of scientific communities. So maybe broadly speaking, a scientific community of biologists, of doctors, of veterinarians, and even within those communities, sub-communities, maybe zoologists, botanists, agronomists, cardiac specialists, and so on. Now, each of these communities tended to have their own rules for membership, so what sort of qualifications counted, what sort of patterns of behaviour and what sort of knowledge mattered, and their own systems of communication. And so they developed distinct vocabularies with their own jargon, their own terminology. They developed their own means of communication. So, for example, discipline-based journals, discipline-based conferences. They also, perhaps less obviously, but I think equally importantly, developed their own rules about what constituted good science, what was good, high-quality research. And they also developed their own priority areas for investigation. And whilst this was very productive and very efficient in developing and promoting those sciences, it left big gaps in between these sciences, which became almost like islands of expertise with little communication between them. So in terms of the history of One Health itself, well, actually, this concept is very, very old. It goes back millennia and crosses many cultures, because what we're talking about is this sort of understanding of the important links that exist between humans, animals, and their environments in terms of their health. So this has been around for many, many years. Thinking from sort of a European perspective, some of the names that crop up in the history of One Health include Edward Jenner, who identified that using cowpox virus, he could vaccinate people in a way that would protect them against the much more serious disease of smallpox. And eventually this observation that what was ostensibly a disease that was caught from animals could protect from a human-only disease has led to the eradication of smallpox. Now, Rudolf Virchow was a physician and a pathologist who is reputed to have stated, although it's disputed whether he said this at all, but he's reputed to have stated that between animal and human health there is no dividing lines, nor should there be. So this sort of suggests that we really need to break down these barriers between at least human and animal health. And Virchow was very much against sort of the rising tide of germ theory that postulated that particular germs were the cause of particular diseases, and he was much more interested in the sort of social and environmental causes of diseases, things like poverty, lack of hygiene, and so on. And he saw that these were the root causes of disease, where things like germs would then, or infectious pathogens would move in to these sort of damaged bodies that have been damaged by poor nutrition, by poverty, and so on. William Osler is sometimes referred to as the father of modern medicine, and he promoted at an early stage this concept of One Health. John McFadden was both a physician and a veterinarian who was instrumental in sort of bringing the veterinary profession in the UK and subsequently elsewhere into the scientific era. So it took it from being sort of a trade, if you like, akin to farriery, into the modern scientific area. Much more recently, Calvin Schwabe from the US sort of reintroduced, perhaps coined, but probably reintroduced this concept of one medicine, which has developed into a stronger idea of one health. And this has led to a number of initiatives. For example, the American Veterinary Association and the American Medical Association passed a One Health resolution back in 2007. And the key international organizations of the FAO, the OIE, and the WHO produced a tripartite alliance for One Health in 2010, in which they set out these ideas of sharing responsibilities and coordinating global activities to address health risks across the animal, human, and ecosystem interfaces. And this has been followed up in many countries around the world who are developing their own approaches to One Health to solve some of their own serious health issues. But what is One Health? Clearly we've talked about animals, people, and environments. And it's a very loose concept that has potentially many definitions and means different things to different people. Some of the earlier sort of diagrammatic representations look like this one here on the left, where One Health is seen as sort of an umbrella term for a whole range of disciplines. So lots of different disciplines sort of fit under this umbrella, things like environmental health, ecology, vet medicine, public health, human medicine, microbiology, some health economics and so on. But they're largely still separate disciplines, at least in this diagram. This sort of conceptualization did recognize that One Health spanned from individuals through to populations right up to sort of ecosystems. But often the focus of this conceptualization was that One Health really covered two broad issues. One was zoonotic infections, so the transmission of disease from animals to people, be they bacterial, viral, diseases or others, including things like antimicrobial resistance. This sort of grouping of issues also included food safety and food hygiene, and a range of interventions that might be applied to humans and or animals to try to reduce the risk of zoonotic infection. The other broad category was that of sort of comparative medicine, where understanding disease in one group, perhaps humans, perhaps animals, could lead to further understanding in the other group. So, for example, understanding a particular cancer and how it develops in one animal species might lead to new ways of thinking or new treatments for people. More recently, the way we visualize One Health has come to change, and it's seen as recognizing that there are these broad disciplinary areas related to animals, related to humans, and related to the environment. And One Health is that area where these concepts interact and overlap. So this sort of representation involving these three parts, human, animal, and environmental, has taken different forms. So we see just three here. And you can see that there are important, perhaps, differences amongst these. The one on the left here particularly refers to human disease and animal diseases, whereas the one in the middle talks about healthy people and healthy animals. So it's useful to think about, are we just focusing on disease, or are we thinking about health in a broader sense? And the one on the right here explicitly recognises the sort of different scales at which One Health operates, the local scale, the regional scale, and the global scale, and also a range of disciplines that interact to form the space in which One Health exists. So the One Health Commission has provided one of several definitions of One Health, and it's one that I particularly like, and it states that One Health is the collaborative effort of multiple health science professions, together with their related disciplines and institutions, working locally, nationally, and globally to attain optimal health for people, domestic animals, wildlife, plants, and the environment. So you can see this covers a whole range of issues. So a visual representation of this that I particularly like is this one, which again delineates One Health as this space that arises through the intersection of efforts to improve the health of people and animals and the planet generally, the environment. And it highlights some of the key impacts of One Health, or the power of One Health as they put it. Things, for example, to preserve the efficiency of tools used in human and animal medicine, so for example antibiotics, ways of limiting disease spread, of lessening livestock mortality and improving productivity as part of a way, amongst other approaches, to improve human nutrition, to ensure that people have not just adequate nutrition but have choices amongst their foods, to conserve natural resources, to boost economies and livelihoods, make them more resilient. It's also important to recognise that One Health doesn't only, in terms of animals, doesn't only apply to wildlife and livestock, but that pets, our companion animals, can improve human health. And also One Health has a role in combating diseases like obesity and diabetes through proper nutrition, but also in certain cultures through pets, which might promote walking and other activities. So within the Horn project, we sort of have adopted the One Health Commission definition, but we recognise that health and well-being are quite complicated concepts. They're multifaceted. They mean different things to different people in different circumstances, but that these ideas arise as what might be considered emergent properties of complex systems. So health and well-being emerge out of systems that link humans, animals, and their social and natural environments. So these systems, these complex systems, cross local, national and international scales, and they can be thought at within those scales and across those scales. And importantly, the One Health approach that we're promoting here requires collaboration among a whole range of scientific disciplines and other stakeholders through what we might consider to be a transdisciplinary approach, and an approach that's participatory, that engages with different stakeholder communities in an open and trusting way. The important thing about thinking about One Health or health and well-being as part of a complex system is that changes in one part of that system can have often profound and unexpected impacts in other parts of the system. So changes relating to livestock production or to perhaps the economic situation can have profound impacts on, for example, human health and other aspects of this system. So to summarise that, One Health approaches require collaboration among multiple scientific disciplines, and that's something we aim to promote through the Horn project. It's also, I think, useful to perhaps see One Health not necessarily as a discipline in itself, but as an ethos, as a way of thinking or an approach to problems. So let's illustrate that by considering different types of approaches to, for example, health issues. So in the classic disciplinary approach, then I would use my discipline, my disciplinary skills, my disciplinary knowledge to address particular problems around one or more health issues. But what I will do within that, what I aim to do, will be dependent on my skills, what it is that my discipline does. And I will be thinking about what are my responsibilities, not only to this health issue, but to my discipline when I approach this problem. If we think about a more integrated approach, we might ask the question rather, well, what can be known about a particular disease? So here we're taking a particular health issue, and we're usually obviously interested in applying our discipline to that issue, but we might bring in other disciplinary areas as well. So we're doing some multidisciplinary research, trying to understand a particular health issue. I think the One Health approach aims to go somewhat further. The sort of questions we might want to ask here are that how can we actually resolve this health issue? So for example, if we're interested in the first health issue here, we may recognize that we need multiple different disciplines to work on that issue, but we also recognize that perhaps we need to be tackling other issues as well. This issue shouldn't be viewed in isolation. There may be related health issues, there may be other issues not related directly to health, but things like economic issues, issues of access, of gender equality, of regulation, cultural issues, other scientific issues, and so on. And so we need to think very broadly about the whole system that has led to this particular health issue arising, and to think about how we might address that. So I'd like to give you just perhaps a quite simplistic example of what I consider to be One Health thinking, and I'd like you to think about other issues that you're interested in and how you might be able to tackle them in similar ways. So let's just consider a single event here. We have an elderly lady, 75 years old, who's been killed after being hit by a car while she was crossing the road. Now, the driver of the car had been drinking alcohol and was over the legal alcohol limit. So the question we might ask is, what is the cause of death? So if you think about that for a moment, and then compare your answer with some of the ones presented here. So here we have a range of different specialists, and what they, in this example, might say was the cause of death. So, for example, the pathologist who's inspecting the woman's body at post-mortem examination might think that it was a ruptured spleen was the event that led to her death. The clinician in the emergency room might put it down to hemorrhagic shock. Now, the surgeon might claim that actually if this person had got to their operating theatre faster, they could have been saved, so the delay in getting to the operating theatre was the problem. A local leader might say, well, if we hadn't closed the local hospital, then of course we could have got the person to the appropriate medical care faster and they would have lived. It might go down in public statistics as a death caused by a motor vehicle accident. A highway engineer or road engineer might say that the poor maintenance of the road was a contributing factor. A car engineer might suggest that actually it was delayed braking that was the problem, and of course the police might point to the influence of alcohol leading to that delay in braking. So we see quite diverse potential explanations of why a death occurred in this case. But let's think about it more as a system. So here we have the event that we're interested in, which is death. And we can see actually that rather than these disparate causes being completely separate from each other, actually we can start to see that they're related. So for example, maybe one of the causes that led to death was hemorrhagic shock. The rupture of the spleen led to the hemorrhagic shock. Obviously it was the motor vehicle accident itself that led to the ruptured spleen. A range of issues such as delayed braking, which might have been precipitated or made worse by the poor maintenance of the road and the influence of alcohol, led to an increased risk of a motor vehicle accident. Other factors like the closure of the hospital would have led to delays in getting to the operating theatre, and that delay might have made it more likely that the ruptured spleen would lead to hemorrhagic shock, and that hemorrhagic shock would lead to death. And then we can add a whole range of other factors that haven't been discussed yet, a whole range of political and economic factors that have influenced whether the hospital closed or not, the quality of the roads, the characteristics of the pedestrian herself, her age, was that a factor, any pre-existing illnesses, and so on. We can also start to see that perhaps there are some unexpected relationships here. So for example, if we decided that one way to try to reduce the motor vehicle accident deaths was to improve maintenance of roads, what we might find is that the speed that people travel on those roads increases, and that makes motor vehicle accidents more likely, or perhaps if they do occur, it makes them more severe and more likely to lead to death. So again, we have these sort of loops that might feed back and influence what's happening in complicated ways. This sort of systems thinking also enables us to think about what might be called proximate or downstream causes of the outcome of interest, and ultimate or upstream causes. So proximate ones are those that are very closely related to the outcome we're interested in here. So for example, things like hemorrhagic shock is probably one of the immediate causes of death, whereas things like the social and political factors that contribute to the road maintenance, to the sort of social acceptability of drinking and perhaps driving under the influence of alcohol, might be considered a more upstream or ultimate causes of this outcome. And what we can see from this diagram is that all of these suggested causes actually provide different ways that we could intervene in this system to try to reduce the risk of motor vehicle accidents or of death following motor vehicle accidents. So it provides us with a whole array of different intervention approaches that we might like to consider, perhaps more than each of those individual people would have come up with if they just focused on their own understanding of the cause of death in this case. So to work in One Health requires us to think differently, to act differently. And this is something, again, that we will be promoting and encouraging through the Horn Project. It requires us to think about systems. So these might be agricultural systems, healthcare systems, ecological systems, economic, political and social systems. And we need to think about how these systems interact with each other. We then need to reconceptualize the problems that we're dealing with and the solutions we face. We have to avoid thinking only within our own expertise and our own training, and we need to think and try to understand different ways of framing or different ways of understanding the issue that we're dealing with. We have to understand what are the competing priorities, what matters to different people in this situation, and what is the full range of alternative solutions that we could apply. To do this, we need to foster what we might call transdisciplinary working across the disciplines, not within them. So we need to be able to engage and collaborate with a whole range of relevant scientific communities, but also non-scientific communities. We need to develop a common vocabulary. We need to establish trust. We need to ensure we respect one another. And we need to be humble. Okay, we need to recognize that our own expertise and our own training is part of the picture, it's part of the solution, but we shouldn't expect it to be the whole solution. So if we're trying to develop a One Health perspective about a particular problem, then it's useful to run through a series of questions. Now, this is just a shortened list from this book that's mentioned at the bottom corner of this slide, but these might help you to start thinking about ways that you can think in a One Health, from a One Health perspective. So we could ask, what are the systems, be they agricultural, economic, health, and so on, that are involved in this problem, and how do they interact? So that might require us to map out these systems and to explore with other experts how we think these systems work, what contributes to them, and how they interact. We should also think historically, what's led to these systems being the way they are now? What has stabilized them, so what has sort of caused them to be structured in this particular way, and what in the past has been shown to destabilize them, to cause change? We need to identify the principal stakeholders, but we shouldn't just do that. We need to think, well, how are these principal stakeholders being identified? Who's determining who is important to this question? Are there conflicts of interest between these people that we need to be aware of and that we might need to work with in the future? Are there particular power dynamics or gender issues that apply? And it's also useful to think about who is being ignored in this process. Are there people who are underrepresented, or groups of people that are being underrepresented that we should try to include in this activity? We can also think about the ways in which the issues are being framed. How are they being described? How are they being prioritized in different ways by different groups? It's also useful to think about each group and what sort of assets, what resources, what knowledge they can bring to understanding and solving this particular problem. And are there particular resource constraints that need to be addressed? We can then start thinking about the critical issues, not necessarily within our own discipline, but across this broad system. What is critical to understanding the way that this problem has arisen and perhaps the way that it can be resolved? How do these issues interrelate? And it's useful to think about what sort of spatial scale and temporal scale they operate. So is it a very local issue? Does it involve regional or national effects? Is it an international problem? and over what timescale? Is it just a very short-term thing, or is it a very long-term problem? Then we can start to determine what further information we need, and what action could be taken to try to resolve the issue. We also, of course, when we're thinking about action, we need to think about how these solutions might be acceptable, affordable, sustainable, and equitable to the people involved. So you can see that developing a One Health perspective is a complex problem that is probably difficult for any single individual to do on their own. So it does require communication with others. And of course that requires us to develop a common language. So we need to take time to understand each other's perspectives and to understand the words that each other use when describing particular problems and solutions. So just to finish off with a brief summary, what I've tried to highlight is that the concepts that underpin One Health really are not new, but I think over recent sort of Western scientific thinking, they've been largely ignored. And this really stemmed from the 17th and early 18th centuries, with the scientific revolution that led to the formalization of scientific disciplines and to their sort of walling off of these disciplines from each other, which led to a lack of communication amongst particular scientists. Of course, there are notable exceptions, but the links between human, animal and environmental health have in the past, and I think often still are now, ignored. So One Health, this concept of One Health, specifically recognises the importance of these links between these sort of human, animal and environmental contributors, and calls for active and meaningful collaboration between a whole range of disciplines involved in these areas to try to address problems that relate to these particular problems and these particular areas, and that often overlap and spill from human health into animal health or environmental health, for example. So as I say, this requires development of common vocabulary. We need to learn how to communicate with each other. We need to think in terms of systems. We need to be prepared to reconceptualize, to reframe problems, and we need to include multiple perspectives, and we need to build trust amongst different groups. I'll leave you here with a very short list of some additional reading, and I hope you enjoy the program that we're presenting as part of the One Health project. Thank you very much.